Hi class, this is Dr. Shahada, and in this video I will be reviewing Chapter 9 titled Managed Care in Integrated Organizations. So here is some info from the chapter section from this week's module. The first portion of it covers Chapter 6 and the last portion covers Chapter 9. Now, as in our previous videos, really quick, I want to make sure that you know you have your PowerPoint presentation, which is right here. It's actually the continued one, which is for Chapter 9. And here is the terms and definitions for Chapter 9. So as I go further down, we start covering some of the information from Chapter 9. So let's begin really quick by looking at this diagram. I'm going to explain a little about it, and then we're going to jump to the PowerPoint presentation for Chapter 9. So one of the most important questions in this chapter that is answered is, what is managed care? So managed care is an organized approach to delivering a comprehensive array of healthcare services to a group of enrolled members through efficient management services needed by the members and a negotiation of prices or payment arrangements with providers. Now, there are two main features of managed care. As you can see, they're listed right here. It integrates the functions of financing, insurance, delivery, and payment within one organizational setting, and it exercises formal control over utilization. All right, so as you can see here, with payment, insurance, delivery, and payment, MCOs or managed care organizations also integrate the quad functions of healthcare delivery, which we have reviewed previously in this course. Now, MCOs eliminate insurance and payer intermediaries and realize some savings. Risk sharing promotes delivery of healthcare that is economically prudent. So with risk sharing, it's an indirect method of utilization control. Cost savings are achieved by coordinating a broad range of patient services and by monitoring care to determine whether it's appropriate and delivered in the most cost-effective setting. So most providers find the complexity of having to deal with numerous plans overwhelming. A tremendous amount of inefficiency is created as providers must deal with the protocols adopted by each plan. Carved out services present certain inconveniences for both patients and providers. And there's another area of inefficiency, and that is the lengthy appeals process that patients and providers must sometimes go through when an MCO denies service. I just wanted to touch on that when we were looking at this diagram here, just quickly illustrating the services that occur before actual delivery of healthcare service and what occurs after the services are delivered. Again, here are the financing, insurance, and delivery and payment, the quad function of a healthcare delivery system, which we have went through previously. And what I just touched on, just to make sure for those of you that made note of it, I was really focusing, other than just the integrating of these quad function, there's also some of the inefficiencies that are created by managed care that need to be touched on. Now, the next section talks about the evolution of managed care, which I'll be covering in the PowerPoint presentation. So now I'm going to switch over to the PowerPoint presentation for Chapter 9, and I'm actually going to start with slide number 7. All right, so really quick, medical loss ratio. Now, this term was actually covered in Chapter 6. I know that I didn't talk about it in the Chapter 6 presentation, but it's the percentage of premium revenue spent on medical expenses. So the remainder is used for administration, marketing, and profits. Now, with the Affordable Care Act, the ACA actually prescribes minimum medical loss ratios in health plans to limit the percentages of premium revenue a health plan can use for administration, marketing, and profits. Okay, so this MLR, medical loss ratio, is actually expected. It's to be expected that the industry would invite further regulations should premiums rise above what the government may consider unreasonable. Okay, so here it mandates a minimum of 85%, while the rest covers overhead. Now in the next slide, I will be discussing payment. All right, just to let you know, slide 8 and 9 actually pretty much say the same thing, so I'm going to be deleting one, and you will have the updated version in the course. So let me do that real quick before I continue and speak about the three main types of payment for MCOs. So here we are. Now, MCOs use three main types of payment arrangements with providers: capitation, discounted fees, and salaries. Under capitation, the provider is paid a fixed monthly sum per enrollee. All healthcare services are included in the one set fee, so that risk shifts from the MCO to the provider. Discounted fee arrangements can be regarded as a modified form of fee-for-service. After services have been delivered, the provider can bill the MCO for each service separately, but is paid according to a pre-negotiated discount schedule. So in this case, risk is borne by the MCO, but the MCO is able to lower its cost by paying discounted rates. Now, when we're talking about salaries, which are frequently coupled with bonuses or withholdings, salaries are actually paid when the provider is an employee of the MCO. So often, at the end of the year, a pool of money is distributed among the physicians in the form of bonuses based on utilization or other evaluative measures. So the bonuses are not paid if the predetermined performance objectives are not achieved. Under this method, risk is shared between the MCO and the physician. All right, now that we've covered the three main types of payment, I will be covering the topic of the evolution of managed care. All right, so we really started with the first private health insurance arrangement, which was the Baylor plan. We covered it in Chapter 3, and it was based on capitation. So in which a fixed monthly fee was paid to Baylor Hospital for every teacher who enrolled. This was done without involving an insurance company. Now, contract practice came along, and it takes the idea of capitation a step further by incorporating a defined group of enrollees. It also shifted some of the risk to providers. Then we look at prepaid group insurance. This is where it provided more comprehensive services. So it preserves the principle of capitation, bearing of the risk by the provider and a defined group of enrollees whose health care contract is financed by their employer. But it then goes a step further and adds the delivery of comprehensive services. And then we get to managed care. And this is where everything listed above is included, but it goes a step further and it includes utilization controls. So that kind of gives you an idea of this evolution of managed care. Here's another figure that goes through the evolution of managed care, and it's also a little more detailed. As you can see, it touches on health insurance, the Baylor plan, and then goes through the contract practice, what's added with the prepaid group practice, and last, how managed care takes all that a step further with utilization controls. All right, so now I'm going to jump to slide number 15 and just briefly talk about the HMO Act of 1973. Now, the objective was stimulating growth of HMOs by providing federal funds for the establishment and expansion of new HMOs. Now, the belief was the growth of HMOs and prepaid medical care would stimulate competition among health plans, enhance efficiency, and slow rate of increasing rates in health care. And it was signed by Nixon and failed to increase HMOs. And now I want to talk a little about the growth of managed care. Now, there was flaws in the fee-for-service, also known as indemnity insurance, which was actually preferred by providers, but with managed care, it offered relief from the rapid cost increases under fee-for-service, for the fee-for-service system. So before managed care, under the fee-for-service system, we had uncontrolled utilization. Now let me go to the next slide before I get any deeper, talking about the flaws of the system. So first, before managed care, again, we had it was fee-for-service. Patients were free to go to any provider. Competition was driven by the impression of high quality. So this is where specialists and sophisticated technology come into the picture. And there was little control over prices. Providers charged or utilization of services by patients. Costly hospitalization for patients were more lucrative for physicians. So again, remember, flaws in fee-for-service. I just want to go over this a little bit more. There was uncontrolled utilization. All right, so this led to moral hazard, overutilization of specialty care, and provider-induced demand. Second, there were uncontrolled prices and payment. So we're talking about charges that were being set artificially high. Insurers were passive payers of claims, and there were inefficiencies absorbed by raising premiums. Then third, focus on illness rather than wellness. So there was little emphasis on prevention and more focus on what was lucrative for physicians and, how it was lucrative for physicians to hospitalize their patients. All right, now the next slide. So the main factors that contributed. So the first one, flaws in fee-for-service, which I just briefly touched on. The second one, the cost appeal of managed care. All right, so regarding cost appeal of managed care, let me jump to slide number 21. Here we go. So we're looking at shadow pricing. So that's HMOs started offering better benefits at lower costs, is essentially what it is. And then there was the general resistance from employees due to restricted choices and a resistance from providers due to the threat of lower incomes and external controls. Okay, so there was this general resistance from employees and providers. Then we have employers that found it economically necessary as premiums were rising about 12% annually. And then the last factor that contributed to this growth was a weakened economic position of providers. Okay, so we have those three factors. Flaws in fee-for-service, which we reviewed, cost appeal of managed care, and last is weakened economic position of providers. Now, the two factors that contributed to this weakened economic position was excess capacity in hospitals, and physicians gave into the momentum of managed care. They wanted to participate or be completely left out. Now, I want to jump to slide 23, and I'll be discussing the efficiencies and inefficiencies in managed care. All right, so here's a little table that compares the efficiencies and inefficiencies of managed care. So let's first start covering the efficiencies. First, the elimination of insurance and payer intermediaries. Second, the risk sharing with providers to minimize provider-induced demand. So this indirectly controls utilization through prudent delivery of healthcare. Then there's the coordination of a broad range of services and monitoring the delivery of services for appropriateness and cost efficiency. So an example of this, or of the third one listed there, is emphasis on outpatient care over hospitalization. The fourth one is gatekeeping reduces moral hazard. And then we have preventative care that helps detect and treat health problems. All right, now for the inefficiencies. So we're looking at the complexity for providers of having to deal with numerous plans. Laboratory and some other services are carved out, so there's more of a convenience factor for consumers. Lengthy appeals when services are denied. All right, so now I'm going to jump to utilization monitoring. All right, let me just find the slide here. Okay, so here's a number of different methods that are used in managed care for utilization monitoring. So the first one is choice restriction. I do want to point out, I'm going to go through everything listed, but my slides are pretty detailed. So what you'll notice is everything is pretty much listed on the slides. If you have any questions, do not hesitate to let me know. All right, if you felt like I went over something too fast, just email me and I could describe to you in the email in more detail what I was covering for that specific section. So here we go. The first one is choice restrictions. So with choice restriction, here I'll even jump to the following slide so it doesn't get too confusing for you guys. We are looking, patients still have a choice of physicians, but the choice is limited. So in choice restriction, it actually indirectly controls utilization. Physicians that have a formal affiliation with a managed care organization are on the panel. So we have a closed panel, which means closed access in network. So services can be obtained only from providers affiliated with the plan. You also have an open panel, which is open access out of network. Access to providers outside the panel is allowed, but at higher cost sharing to discourage open access. So you're putting more out of your pocket because it's a higher cost sharing than closed panel. And then you have utilization, which is better managed under closed panel. So earlier, this method had caused some dissatisfaction among enrollees, but now they're more willing to accept limited choice to save out-of-pocket costs. So that was pretty much what we got out of this cost control method. The next one is gatekeeping. So the primary care physician is pretty much the portal of entry into the healthcare delivery system. It is responsible for managing utilization, or he or she is responsible for managing utilization, since we're talking about the PCP. And the PCP delivers all basic and routine care, and the PCP determines the need for secondary care and makes referrals, which we've all seen this with HMOs. Now, I just realized I did not define or go through in detail what an HMO is. I will be sure to do that later on in this lecture, okay? Now, with gatekeeping, again, it emphasizes preventative care, routine physical examinations, and other primary services. So here, you actually see the care coordination and utilization control through gatekeeping and how the PCP is right in the heart of it all. The next method is case management. So case management is an organized approach to evaluating and coordinating care, especially for patients with complex, potentially costly problems. So we're looking at coordination of care for complex and potentially costly cases. Examples include AIDS, spinal cord injury, transplants, and severe injuries. Now, an experienced healthcare professional coordinates or will coordinate individuals' total healthcare in consultation with primary and secondary care providers. An example of this would be a nurse practitioner with knowledge of available healthcare resources. And I've also, in projects I've been involved in, they've used patient navigators, which usually were nurse practitioners that guided the patient on what stages need to be done and who they need to make appointments with to guide them through the healthcare system. And it's the same idea, but with a nurse practitioner, it's more as a guide and not, it's usually, a healthcare intervention type of project. And with the project I was involved with, it had to do with breast cancer and providing the proper health care for underserved populations. So they were actually not, they weren't they didn't have to pay for those services, but it made sure that the right services were, not taken into account, but that the proper services were provided to the patient. So that was why they put this patient navigator, which is essentially what we're talking about here. But of course, in this case, with case management, we're looking at a cost control method. Then we have disease management, a population-based orientation strategy for people with chronic conditions, and this is where enrollees are identified by a disease. An example would be diabetes, asthma, depression, coronary artery disease, etc. So the focus is on education, self-management training, monitoring of the disease process, and follow-up to ensure compliance. Now, the goal here with disease management is prevent or delay complications, lower emergency room visits, and hospitalizations. That is the goal. Now, the next topic I'm going to be covering is utilization review. All right, so with utilization review is the process for evaluating the appropriateness of health services utilization. So it requires a review of each case, determine the most appropriate level of services, ensure cost efficiency, and plan subsequent care. And utilization review falls into 3 categories that I will be going over in the next slide. So the 3 types are prospective utilization review, concurrent utilization review, and retrospective utilization review. So those are the 3 types. Now, first, I will begin with the prospective utilization review, which is listed on this slide. So under this method, appropriateness of utilization is determined before the care is actually delivered. The decision by a primary care gatekeeper to refer or not refer a patient to a specialist is a type of prospective utilization review. Other examples include pre-authorization of hospital admission and second opinions for surgical procedures. The main benefit of prospective review is that it prevents unnecessary or inappropriate services before they're rendered. Now, with the second type of utilization review, which is concurrent utilization review occurs when decisions regarding appropriateness are made during the course of healthcare utilization. The most common examples of this type of review involve the monitoring of inpatient lengths of stay and discharge planning. A certain number of inpatient hospital days may be pre-authorized, but any extended stay would require authorization. The main benefits of concurrent review are to prevent overutilization of inpatient hospital services and to facilitate discharge planning. The third type of utilization review is retrospective utilization review. So this refers to managing utilization after services have already been consumed. A close examination of medical records is undertaken to assess the appropriateness of care. Retrospective review may also involve an analysis of utilization data to determine patterns of overutilization or underutilization. So it also allows monitoring of billing accuracy and compilation of provider-specific practice patterns. Such statistical data can be helpful for taking corrective action and for monitoring subsequent progress. Now, next I will be jumping to the slide that covers types of managed care organizations. All right, so here are the three types of managed organizations that I'll be going over: HMOs, PPOs, and POS plans. Now, an HMO stands for Health Maintenance Organization. It is a type of managed care organization that provides comprehensive medical care for a predetermined monthly fee per enrollee. All right, so let me first start with HMOs, and we'll go through them, and then I will go over a PPO and a POS plan. Now, there are three factors responsible for leading to these three different types of managed care organizations. And the idea, managed care organizations, sorry about that. So these three factors are choice of providers, different ways of arranging delivery of services, and payment and risk sharing. All right, so let's begin with HMOs. HMOs emphasize preventative care. They offer a variety of services to help people maintain their health. Now, as we've mentioned before, PCPs are the first contact for basic care. They coordinate all healthcare services, and they make referrals for secondary care services as needed. We have capitation, which is provided services receive capitated fees regardless of whether the enrollees use healthcare services or not. In-network access, this helps carve out for special services, and HMOs are responsible that services comply with the standards of quality. Now, HMOs may employ physicians on a salary. Now, really quick, I want to jump to PPOs, and then I will go into detail regarding the 4 models of HMOs, because there's a lot of information when we speak about health maintenance organizations. Okay, I'm going to briefly cover PPOs and the POS plans, and then I'm going to jump back and speak about the 4 models of HMOs. So PPOs, which is the second type of managed care, the second type listed for a managed care organization. They appeared in the 1970s. It's a discounted fee for service is the primary method of payment. There's little or no risk sharing with providers. It does not use the gatekeeping method as HMOs do with the PCP. It allows enrollees to go outside the panel, and it uses only contractual arrangements with physicians. So what's the appeal here with PPOs? Well, it allows patients the choice of using physicians and hospitals outside of the panel. Now, exclusive provider plan. So it's similar to a PPO when you have an exclusive provider plan, but it does not provide an out-of-network option. Then we have the POS plans. So just quickly to make sure you're aware, I'm sure if you've read the chapter you know this, but point of service is what POS stands for. So a point of service plan combines features of classic HMOs with some of the characteristics of the patient choice found in PPOs. The features borrowed from HMOs are capitation or other risk-based reimbursement to providers, and the use of gatekeeping, the gatekeeping method of utilization control. The feature borrowed from PPOs is the ability of a patient to choose a non-participating provider at the point of receiving services. So, however, out-of-network utilization incurs higher out-of-pocket costs. Point of service plans grew in popularity because choice of providers had a special appeal for most enrollees. Over time, as HMOs relaxed some of their utilization control practices, and PPOs already offered a choice of providers, the need for a hybrid plan became less and less important to consumers. So the main objective, retain the benefits of tight utilization management and offer an alternative to their unpopular features of restricted choice. All right, so now I'm going to jump back to the 4 models of HMOs or health maintenance organizations. And really quick, before I jump and do that, when we're talking about PPOs, we are talking about preferred private provider organization. I should have said that when I reviewed the slide on PPOs. All right, so now back to HMOs. All right, so the 4 main models for HMOs are staff model, group model, network model, and the independent practice associations model, or IPA. Now, a staff model employs its own salaried physician. So I'm going to jump to the next slide since we're speaking about staff model. So let me repeat that. A staff model, HMO, employs its own salaried physicians. It's based on physicians' productivity and the HMO's performance. Bonuses may also be paid on top of the salary. Physicians work only for their employer HMO and provide services to the HMO enrollees. Staff model HMOs must employ physicians in all of the common specialties to provide for the healthcare needs of their members. Contracts with selected subspecialties are established for infrequently needed services. So there are 2 main advantages here. 1, the HMO is able to exercise control over the practice patterns of their physicians, making it easier to monitor utilization and build a common culture of care delivery. Second, staff model HMOs also offer the convenience of one-stop shopping for their enrollees because most common types of services are centrally located in the same clinic. Now for disadvantages. There's 2 main disadvantages. First, the large fixed salary expense, which often prevents expansion into new markets, which I have them as the first 2, and then a limited choice of physicians for the enrollees. So the nationwide, the number of HMOs following the staff model have declined. The next model is a group model. So a group model HMO contracts with a multi-specialty group practice and separately with one or more hospitals to provide comprehensive services to its members. The physician in the group practice are employed by the group practice, not by the HMO. The HMO generally pays an all-inclusive capitation fee to the group practice to provide physician services to its members. Now, advantages of the group model, which I'm going to go to the next slide to explain, include leverage regarding financial terms and utilization controls, since the HMO brings a block of business to the group practice. Second, avoiding large expenditures in fixed salaries and facilities. Okay. Third, a certain degree of prestige and perception of quality if the HMO is affiliated with a reputable multi-specialty group practice. And then disadvantages include a disruption of the delivery of services if the contract is lost, and limitations in the choice of physicians. Next model is the network model. Now, under the network model, the HMO contracts with more than one medical group practice. A common arrangement is to have contracts only with group practices of primary care physicians. Enrollees generally have the choice to select physicians from any of these groups. Each group paid a capitation. Each group is paid a capitation fee based on the number of enrollees. The group is responsible for providing all physician services. The group can make referrals to specialists, but is financially responsible for reimbursing them for any referrals it makes. And now, regarding advantages to the network model, one, the model is specially adaptable to large metropolitan areas and widespread geographic regions where group practices are located. Generally, the network model is also able to offer a wider choice of physicians than the staff or group model. Now, the disadvantage, the main disadvantage is the dilution of utilization control. Now, the next model is the Independent Practice Association model that I will be covering. Now, with this model, an HMO contracts with an organization, the Independent Practice Association, that is separate from the HMO. So the IPA establishes contracts with both independent solo practitioners and group practices and functions as an intermediary representing a large number of physicians. The IPA is generally paid a capitation amount. It may in turn reimburse physicians through capitation or some other mechanism such as modified fee-for-service. Now, in the next slide, I'm going to cover the advantages and disadvantages of the IPA model. One, the HMO is relieved of the administrative burden of establishing contracts with numerous providers. Second, financial risk is transferred to the IPA. Third, the IPA model provides an expanded choice of providers to the enrollees. Fourth, it also allows small groups and individual physicians the opportunity to participate in managed care and get a slice of the revenues. Disadvantages. The major disadvantage of the IPA model is that if the contract is lost, the HMO loses a large number of participating physicians. The IPA does not have as much leverage in changing physician practice behavior as a staff or group model HMO has. So the utilization controls are diluted. And third, many IPAs contain a surplus of specialists, which creates some pressures to utilize their services. Now in the next slide, here is a little figure on how the IPA functions. Next, I'm going to cover highly integrated healthcare systems. So let me just find the slide. So when we're talking about highly integrated healthcare systems, these generally include a hospital, a physician component, and at least one system-wide contract with a payer, such as Medicare or an MCO. Now, an integrated delivery system. We have three that we're going to be covering. It's integrated delivery system, IDS, accountable care organization, and payer-provider integration. Now, an integrated delivery system, we're looking at a network of organizations that provides or arranges to provide a coordinated continuum of services to a defined population and is willing to be held clinically and fiscally accountable for the outcomes and health status of the population served. Recent studies show high rates of enrollee satisfaction and improved quality of care, but not cost savings. Now, managed care promoted the formation of IDS because it's cost effective for MCOs to contract with a full service provider. There was that preference by MCOs to seek cost efficient providers who will take responsibility for quality, and providers strengthened their bargaining power with MCOs and protected their autonomy. There was member satisfaction is higher in integrated plans. IDSs have had a positive effect on quality of care, but cost savings have not materialized. Both hospitals and physicians are integrating at an accelerated pace. Now, I very briefly want to touch on this integration that we're talking about when we're referring to integrated delivery system. Integration refers to various strategies that healthcare organizations employ to achieve economies of operation, diversify existing operations by offering new products or services, or gain market share. Now, the ultimate aim of integration with these highly integrated healthcare systems is to provide a seamless array of services around the hospital, which functions as the central core. So such an organization would be a health system that's capable of fulfilling most of a community's healthcare needs. Okay, so now I'm gonna start reviewing the accountable care organizations, which is another type of highly integrated healthcare system. So ACOs are an integrated group of providers who take responsibility for delivering services to a defined population. So they take responsibility for improving health status, provide cost-efficient care, and focus on satisfaction with care. Now, ACOs may appear as a newer form, but they encompass concepts earlier proposed and used by HMOs and later by IDSs, or integrated delivery systems. So the ACA has authorized a shared savings program based on meeting cost and quality objectives. However, there are certain concerns pertaining to the participation by small physician groups, the inclusion of safety net providers, and the potential of monopolistic behaviors that remain unaddressed. And the last integrated, highly integrated healthcare system that I will be covering is payer-provider integration. So this is where insurance companies have started to acquire large physician practice groups and health systems as a strategy to gain more control over the delivery of healthcare. It's on the rise. Hence, there's that collaboration between MCOs and providers that could be the next major trend. And the reason for this collaboration between MCOs and providers, which was something that physicians, providers were not very fond of, is due to the fact of the encroachment from a powerful adversary, or that involvement, possible involvement of the government. All right, so that pretty much ends my lecture. I know I didn't cover everything, but I do want to make sure, as I tell you in every lecture, that I just wanted to go over some of the things that were covered. Make sure to read the chapter and go through the full PowerPoint presentation. Make sure to go through the trends in managed care, trends in Medicaid enrollment, Medicare enrollment. There were a couple of topics that I did not cover, but I hope you find this lecture helpful. And again, if you have any questions, do not hesitate to let me know.